Hello and good afternoon, everyone. We're going to go ahead now and get started on our trauma management lecture. My name is Sean Bear, and if you're joining us today for this particular lecture, welcome. So we don't have a whole lot of forward, so to speak, but we're just going to dive right into it. It'll be a little bit different than a lot of the conversations we've had throughout the semester. We're familiar with a lot of the systems of the body, but we're not familiar with a lot of the systems from a trauma perspective. So this will be more of an isolated lecture, but really important as we step into your final exam in the near future. So let's go ahead and get started. I'm not big on terms. You guys are more than welcome to come back, look at terms. I'm going to be using these terms throughout the lecture, and we will discuss them a little bit more in depth. So let's just get after it. Okay. So, trauma. Whenever we discuss trauma, we have to discuss the fact that there is a force, and usually that force in this particular instance is going to be kinetic energy that has acted up on the body and resulted in either external or internal injury or both. Okay. So when we say that there's a trimodal distribution of death amongst trauma patients, what we're really saying is there's a peak incidence where you died instantly on the occurrence when the mechanism of injury acted upon you. Example of that would be we get into a car accident, I hit the steering wheel, immediately send myself into cardiac arrest, cardiac tamponade, etc. I rupture an aorta, sudden death. Okay. Then we have our second peak. Okay. After the initial or first peak, we have a second peak, and that's within the first 48 hours, death occurring resultant of those injuries as well. Okay. And the third is anything after 48 hours. So anything northward of 48 is considered a third peak. So we are now days to weeks, months, potentially even years, depending on the state of the patient. So there's a couple of things we want to consider, and something we don't talk about too much in nursing school is the different types of hospitals and the different tiers of trauma care that exist within even just the local area here which we service or work in. So, we're here in Southern California. We have two local trauma centers in relation to the High Desert campus. Our two local trauma centers are going to be Loma Linda University Medical Center and Arrowhead Regional Medical Center. Loma Linda is a level 1, whereas Arrowhead is a level 2. I'm not going to go into the breakdown just yet of what the different tiers means, but I do want you to understand that not all trauma patients can simply go to any hospital. Okay, there is hospitals that are preferred for certain types of injuries. Even, for example, there's burn centers for burns. There's trauma centers such as Loma Linda and Arrowhead nearby for us that specialize in stabilizing and treating critical or even non-critical injured patients related to trauma. So, be aware of that fact and that that exists. In fact, if you worked at San Antonio, St. Bernardines, um, St. Mary's, Valley, Barstow, or even Desert Valley, you'll see that a lot of the times when we have these severe trauma patients come in, they don't even really hit the ER doors unless they need to be stabilized prior to transportation elsewhere. So what you'll see is they come into the ER, immediate transfer or stabilization occurs, or we attempt immediate stabilization and try to fly them out as soon as possible if they are in a critical state. And again, Loma Linda and Arrowhead being our two main vectors. Now, we do have the 15 freeway and the corridor working our way through here into Victorville and out towards State Line and into Las Vegas. If an accident were to occur on the 40 freeway or the 15 freeway further out toward that border, you may see us change gears here and say, all right, they're going to go to Las Vegas. Okay. Now, I'm not obviously expecting you to know Vegas versus down the hill, but I'm just pointing out trauma centers aren't right next to each other. Okay. Arrowhead and Loma Linda serve a very dense population down the hill in the Inland Empire. This is not the case for a lot of the trauma centers. The nearest trauma center after that is going to be out in Pomona. Okay, or all the way down in Palm Springs. So there's actually quite a bit of distance usually between these centers. So they're not just something, all right, I can throw a stone at and hit one. Just kind of a food for thought. So, mechanism of injury. We definitely need to talk about our mechanism of injuries. We have all sorts of ways that the body can be injured. One of the number one ways is us doing stupid things. In this case, actually, it looks more like a fun thing, actually. But right here, okay, we got kinetic motion and energy at play. This individual is riding downhill on a mountain bike. Okay, downhill mountain biking is really big in the local mountains. All it takes is a tumble at a higher speed coming off that bike, and it can result in a variety of injuries, which we'll kind of talk about moving forward. Okay. So there is trauma scores. I'm not going to make you know trauma scores, but I definitely need you to understand GCS as it relates to traumatic injury. Okay, again, I'm going to reiterate, I do not need you to know the trauma scoring setup. If you go to a trauma center, there's a lot of modified trauma scoring tools or screening tools. And in many instances, they will not only teach you that, but yeah. So the TRIS is one such example of a combination slash revised tool. And what it does is it uses both the injury severity score and the revised trauma score to essentially dictate or to identify suspected survival rates of an individual who has experienced trauma. So, trauma. If we want to talk about the TRIS scale, okay, this is actually how it's scored, and I'm not going to score it myself, but you can see here if you ever see a TRIS and you see a scale of 1, that's a good thing. 2, moderate, 3, serious, 4, severe. They're pretty much the same thing to me, but critical, 5, and unsurvivable is going to be 6. So if you ever see TRIS, that's the indicator there. I do want you to know what the TRIS score at least is and what two combining components it uses. The injury severity score and the revised trauma score in conjunction together, combined, give you the probability of surviving a traumatic incident. Okay. So we're going to move past this. We already know the GCS. I'm going to have you touch up on the GCS purely because it's something I definitely need you to know. Ideally, 14 to 15 would be our GCS. And again, we're measuring verbal responses, painful and eye-opening. Okay, so lowest score possible is a 3. Even a dead body gets a 3. Highest score possible is a 15. That's what I want. Okay. I'm not saying that these are the criteria. We've already discussed and previously lectured on the criteria. If you can't remember them, please go look them up and how to score them. But generally speaking, the revised trauma scale has relation to the GCS scale in that we have the ability to associate systolic blood pressures and respiratory patterns to those GCS scores. And that's what we're seeing here. GCS 13 to 15, it's going to be greater than 89, 10 to 20, 29 in this instance. Usually they're doing pretty good. And we can see as they deteriorate throughout the GCS, and typically, again, just to reiterate here, a deterioration in GCS is indicative of a neurological change, typically an acute change related to injury in this case, or trauma, whereas our previous discussion surrounding the GCS would have been pertinent to, say, medical conditions. So please keep that in mind as we move forward. So we're going to discuss our phases of trauma care. We have our pre-hospital, we have our emergency department, and so when we talk pre-hospital, we're talking about EMS. Okay, so emergency medical services, talking about your EMTs and paramedics, or as people like to misnomer them, ambulance drivers, and yes, they do drive ambulances, but EMTs and paramedics are different. EMTs are the basic level of emergency medical services, which are absolutely valuable. A lot of people like to kind of look down on EMTs, which is kind of funny because a lot of the EMTs I know actually are better than a lot of the nurses I know. When you have a good EMT that knows what they're doing, it can make a big difference between your patient even making it to the emergency department or not. Likewise, paramedics also run in the pre-hospital capacity as an ACLS tool. And that means they can carry out advanced things like airway intubation, so endotracheal intubation. They can carry out intravenous, intraosseous accesses. They have a set of medications that they can administer to a patient depending on indication for treatment. So there's a lot going on out there, and you have to remember. And we look at some of these patients they bring to the hospital like, oh, you didn't even do anything. And sometimes maybe that is the case. Maybe they didn't do their job quite appropriately. But there's many times, and this is something to think about. If you look it up, the numbers are roughly about 8 minutes response time to the scene, and on scene is supposed to be less than 10 minutes for critical patients. So that's not a lot of time to conduct an assessment, to identify life threats, to enact interventions, and then also to get to the hospital. So maybe they're with them on a faster call, 30 to 40 minutes at most. And they get there, and sometimes we're like, oh, why isn't this done? Oh, you didn't know what you were doing. That's not the instance. Actually, the instance is they've got a lot they tried to do. They innovated. They dropped, multiple IVs. They managed some medications. They established an airway. They gave breathing treatments, all in a 40-minute window. And that's a lot to do. Quite honestly, that's quite a bit. Okay, so just food for thought there. Keep that in mind that EMTs and paramedics, good tool, pre-hospital. They're great with medical and trauma in that little window of time in which they treat. ER, come on in. We do our primary survey and assessment. We do any resuscitative efforts that are necessary. This is where CPR would come into play. Maybe we're continuing CPR from the field. We have our secondary survey / head to toe, definitive care and operative phase, and then we have our critical phase if necessary. All right, so they came into the ED. We said, all right, here's what they need. They went on up to the floor, typically, or they went to the OR, or maybe they went non-trauma. Maybe they went to the cath lab. Okay, and then, all right, maybe afterward they need some critical care. And this is more often than not where we see patients go to the medical surgical ICU after having needed surgical intervention or, chest tubes placed or other interventions that require critical care level. Actually, I'm going to move past all this. Can you identify the fracture? So, what I will do is this is I will discuss the absolute invaluable tools that essentially are x-rays. CTs are huge, especially when identifying head traumas and chest traumas. Also, we do use MRI, but MRIs usually aren't a first line assessment tool or diagnostic tool. But what we can see here is an x-ray. We've seen a lot of x-rays, and maybe you're getting used to seeing more of them, but you can already tell just by looking at this x-ray there's substantially more lung capacity on the left than the right, and that is not how it should be. Okay, so either one of a couple things has happened. Either I have pushed up on the right side due to some injury. Okay, I'm missing a lobe of the lower lung, which is not what's happening here, absolutely not. Or more likely than not, and you can kind of see it down here. It looks like there's a tissue there. What this is blood actually settling in the bottom of the pleural space, creating what is a hemothorax. And that's what we're assessing there. Okay, remember, for a hemothorax or a pleural effusion, we could be assessing chest tube necessity. Over here in the front, you can see we have a pelvic girdle. That's another X-ray. Okay, we take a peek from the front here, see what's going on. This is an open book fracture. The pubic symphysis has separated, and the entire front of the pelvis is flexing in a manner it should not be flexing in. So we can identify, and that's what we're going to do. Now, I'm going to point out, and I want you to know this, there's only a handful of typically life-threatening fractures. Bilateral femur fractures are considered life-threatening due to blood loss potential. Put a star next to that. Bilateral femur fractures can lose anywhere between 2 to 3 liters of blood. So in other words, each femur has the potential to lose 1 to 1.5 liters per femur for a total overall output of 2 to 3 liters on bilateral femur fractures. So we consider those life-threatening. Assessment is necessary and stabilization is acute. Now, the other kind of injury that we would suspect and believe to be a life-threatening risk fracture-wise is going to be called a pelvic ring fracture. Okay, so we rely very heavily on the structures down here in the pelvic floor and the pelvic girdle. Okay, and not just that, but I have some large blood vessels that flow through the area as well. We also have large vascularization of the bones themselves. So when we have a pelvic ring fracture, and that's the pelvic ring, what ends up happening is we actually have the opportunity to lose, once again, 2 to 3 liters of blood just from the pelvic ring fracture alone, not including any other sources. So that's pretty substantial, something we definitely want to keep in mind, something very important to think about. How much blood am I potentially losing? But those are the two major ones related to blood loss. Now, other fractures, including skull fractures, cervical fractures, anything like that, or fractures of any of the vertebrae, run high risk, not necessarily for death, but severe impairment of certain body functionalities critical to life. Now, that could be true. There's actually an old saying, anything C4, C5, we need to stay alive. So anything above that area, you need for vital functions such as breathing, tonicity of the vasculature. So we need it for so many things. It controls respiratory drive, it controls our diaphragm, our intercostals. The list just keeps going. Okay, so if you have an injury to the C4, C5, there's suspected risk, and if you have an injury above that, higher than the C4, C5, we have a very substantial risk, or a very present risk, that we are going to impair certain life-critical functions. So keep that in mind as we kind of move through the rest of the chapter. So let's say, all right, I just got into the emergency department. I just got here. Okay, I arrived, rolling through the door. I am going to a trauma center, or I'm a critical patient coming into an ER. The doctor's going to walk up and do a very, very, very quick assessment, while typically a ER tech is taking a rapid, or a nurse is taking a rapid set of vitals. We're going to take a set of vitals, do a full assessment, and when we talk about the assessment, it's a rapid trauma assessment. Okay, it is often how it's referred. And what we do during this assessment is identify any life-threatening injuries, and we also identify the area of the body most affected by the trauma. Okay, so if I walk up to you and I see, hey, you scrapes on both your knees and legs, but I identify no life threats, then I'm going to slow down a little bit. Okay, it's not that I'm not going to investigate what caused that injury, and I'm not going to not treat that injury, but now I got a little bit of leeway. I have some room to work with. Whereas if I walk up to you, I see scrapes and you're bleeding, it looks like you had a road rash, but then I see protruding vertebrae, or step off, or I palpate and I see that there's severe impairment of the alignment of the spine. All right, that's a little more severe. Or if I see bilateral femur fractures, we're going to get after that very quickly. But that's what that primary survey is for. It's an initial assessment. Is there life threats? Yes. Let's address them. Let's assess them. Let's get after them. No. What are my other concerns and potential interventions and assessment areas? We have initial resuscitation. Okay, so all right, I see that you do have some uh, vital function. Oh, you lost it. Let's get that back. Or maybe you never regained it in the pre-hospital setting. We're now in the ER and we need to regain that vital function. So what would we do in this instance? We would resolve whatever the issue is. If I don't have an airway, I'm going to establish that airway. If I can't get an endotracheal tube, maybe I would look at something potentially like an emergency tracheostomy bedside. And ER physicians are trained in this matter. Okay, that established airways took care of the problem. What if it didn't? What if they're in cardiac arrest related to trauma, cardiac tamponade, etc.? Okay, then we would have to continue and potentially resolve whatever the issue is impairing vital function, and then we could move forward. Okay. Secondary survey, and this is all right. We identified life threats. We already took care of everything. All right, we're moving forward. I really have time now to go over the entire body with a fine-tooth comb, so to speak, and I can identify more not non-life-threatening injuries that are not severe, but are still something that need to be addressed, assessed, and treated nonetheless. So, if I ask you what primary survey is, just uninterrupted, rapid evaluation of vital functions and any life threats. That's what I want to hear. If I ask what initial resuscitation is, pretty simple. Bam. Secondary survey, head to toe assessment in depth. So when we talk about our primary assessment, and I just mentioned it a minute ago, it's brief. Okay, we're looking at airway, breathing, circulation. They put disability in here, but really what we're looking at is neurological status, and then any exposure or environmental control. Okay. So airway maintenance, is the airway open, clear, and maintainable? And what I mean by that is the airway open. Are they talking? Are they breathing? Is there fluids? Is there vomit? Is there blood? Is there foreign obstructions in the airway? If there is, we need to address that right away. Can the patient maintain their airway? If they are not awake, not alert, the answer is no, they cannot. An unconscious patient cannot control their tongue, and believe it or not, your tongue with absolute no tonicity, totally relaxed, no control whatsoever, will actually fall back into the airway and close off the airway, resulting in snoring respirations. So is the airway open? Is it clear? Is it maintainable? A couple other things. You see here, this is called cervical inline stabilization or neutral inline stabilization, as a lot of pre-hospital EMS books call it. What we're doing here, and the goal is to keep then you'll notice that's one straight line, the neck, the vertebrae in the neck, and the spine as one straight solid line. We aren't turning the head left, right, we aren't twisting it, moving it for hyperflexing, hypoflexing, we aren't doing any of that. Neutral inline position. Most of the time, on a medical patient prior to intubation, and maybe you guys have seen this, we do what's called a head tilt chin lift maneuver, where we place a hand here on the forehead under the chin and we tilt the entire chin up, the head down. We kind of hyperflex it up and we open the airway, look down in it, and then drop our endotracheal tube. In instances where trauma is suspected or confirmed, we do not use these techniques. We use, wink wink shooting star on this one, what is called the jaw thrust. And the jaw thrust occurs when we place our fingers directly behind the mandible here and we displace the mandible forward without impairing cervical neutral inline position and stabilization. So the jaw is just getting jutted forward. That's it. And with that opening, we then capitalize on the opportunity and we access the airway with either an oropharyngeal airway, an OPA, a laryngeal mask, or an LMA, or an ET tube or something of that nature. So we're looking to see open, clear, maintainable. That's airway. Breathing. What are we looking to for here? We're looking for rate, depth, ease, and we're looking for some other components as well. So we're still worried about the breathing, and like I said, what I just said was when we look at breathing, we're assessing rate, depth, ease. We're assessing the need for airway intervention, meaning can they breathe on their own? Is their current state of gas exchange impaired or non-impaired? And is it adequate for perfusion and oxygen and carbon dioxide exchange? Okay. Now, something to keep in mind when we see a patient that's compensating, okay, so sympathetic nervous system activation, boom, I'm hit, I have been in a traumatic incident, my body responds, I activate the SNS, increased heart rate, increased contractility, increased respiratory rate, bronchodilation, the whole 9 yards. So I'm already breathing a little bit faster as it is. That rush of adrenaline got me breathing quicker, okay? But now on top of that, there is such a thing as breathing too fast. And remember, when we breathe too fast, we blow off too much carbon dioxide. When I blow off too much carbon dioxide, and and if I'm not compensated, I enter into a state of respiratory alkalosis, okay, which is pretty bad for your body. But essentially, what I'm getting after here is, do I need to intervene? Is the respiratory pattern adequate? Are they breathing well enough? 12 to 20 is my adult rate. Are they breathing below that? Do I need to, use a bag valve mask? Do I need to intubate them? Are they able to protect their own airway? And these are the questions we are asking. And by the way, you may actually hear this kind of phrase, this coined phrase out there, and it's called GCS of 8 intubate. Okay, so if your GCS is equal to or less than 8, there's a general rule of thumb that the patient probably should be intubated, most likely because they cannot manage their own airway. And while there is some degree of truth to this, it is not just universally accepted. You definitely still need to assess your patient's breathing and airway status and then decide from there. C is our circulation and hemorrhage. Absolutely. So circulation, I'm looking for rate, rhythm. I'm looking for my quality. Any life-threatening hemorrhaging or bleeding, I'm looking at the quality of the bleed. And what I mean by that is I'm looking for the characteristics that tell me what kind of vessel this is coming from. If it was coming from an artery, I'd suspect spurting. Okay, so pulsating blood flow, and I would expect bright red or brighter red blood when compared to that of, say, venous blood. Veins, even if it's a large vein, it's going to be an oozing just continuous discharge of blood. If it's capillaries, it's going to be a very, very slow paced oozing. The best way I can kind of talk about this one is remember the last time you got a paper cut, you look down at your finger, you're like, ow, you look, no blood, no blood, no blood. 5 minutes later, you look down, there's some blood oozing out from under where that cut is. So, and that would be a capillary bleed. Okay, so what we're getting after here is controlling the ability of the body to compensate, and we are also looking for any hypotension. Okay. So, and if whatever issues I'm having are related to blood loss in this particular instance, that would be categorized as a hypovolemic type of shock. Okay. Disability and neurological eval, it's real simple. Just do your GCS. Okay, we've done the ABCs, looking at GCS. Some other things aside from GCS that I can take a peek at are my pupillary size. I'm looking for anoscoria, one pupil larger than the other, one maybe fixed, both fixed, gaze potentially fixed. If they're up and to the left or fixed in a gaze, that can indicate cerebral involvement or cervical involvement. And the same thing with spinal cord injury. But pupillary size and reaction is a big one. And please remember, if your right pupil is impaired or fixed, it would mean the injury is occurring on the left side of the brain typically, and vice versa. Left pupil is fixed. We're going to be talking about an injury on the right side of the brain. Exposure and environmental control. Excuse me. Exposure, as opposed the patient as appropriate, ensure injuries are not missed. Yes, you are going to have to cut and expose. You cannot just leave their clothing on. Now, obviously, I'm not just telling you randomly anywhere, go ahead and cut their clothes off, take a peek. What's going on? What I am saying is get them into a dedicated trauma assessment room, get them to a location where you can conduct an assessment while keeping their privacy intact, and remove all of their clothes and look for all signs of detailed, in-depth injury. If the patient is hypothermic due to blood loss or environmental factors, keep them warm. Okay, you got to keep them warm, keep the patient normothermic, and make sure that they don't become hypothermic because that by itself can result in cardiac death. Anyhow, so keeping the patient warm is key. So we have what's called the lethal triad. Okay, and really what we're looking at here is it's I don't know why they just didn't put a triangle in, because it is very much a triangle in the way it's designed. So what ends up happening is I get hurt, I get injured, I have an internal external injury resulting in loss of blood flow or perfusion. Okay. Well, the problem is the less blood flow I have, the less perfusion I have, I resultant have an increase in fibrinogen, and I end up in a state of fibrinolysis, resulting in increased TPA levels. Okay, so what happens is I have increased coagulopathy, meaning I'm not clotting properly, and which means I'm not clotting properly, so I'm going to continue bleeding, and if I continue bleeding, I'm going to go ahead and result in a state of acidosis or hypothermia. So, and when we talk about the lethal triad, we aren't just going to give one treatment for this. We're going to approach this from all fronts. I'm going to, if you're bleeding and we're continuous blood loss, I'm going to provide you with packed red blood cells. I'm going to provide you with other blood products potentially, depending on what you need. I'm going to assess for where the hemorrhage is. I'm going to take care of the actual hemorrhage itself, whether that means 4x4s in pressure, 4x4s acrylics in pressure, a tourniquet, maybe cauterization surgically. I'm going to address those issues. And then lastly, coagulopathy wise, if I need to give substances like vitamin K, the potential exists that I can do that. So, stuff to think about, but essentially, no oxygen, no blood flow equals I'm not going to clot. I need to clot, but I can't, so I'm going to bleed more. All bad. Let's talk about resuscitation. Okay, so if you are coming into the ED, all right, and you don't have an airway established and your patient's unconscious and not has no pulse, we're going to establish an airway in the form of an endotracheal tube. Okay, we are doing so to manage ventilation rate, depth, pressures, and oxygenation or FiO2. So what we're going to also do is we're going to resuscitate them in terms of fluid volume. And when I say resuscitate, so we're going to replace essentially. So if I've lost a liter of blood, I don't just want to lose the liter and move on with my life. I want to find a way to replace a portion of the volume in my vasculature to get blood pressure back up and increase cardiac output. How do I do that? We'd be looking at isotonic solutions, bleeding control, and other colloids that can replace volume. Hypothermia kills, talked about that. We're going to monitor in the ICU, NG-OG tubes for decompression and nutrition. Secondary survey, after you do the ABCDE or ABCD, head to toe evaluation and vital signs, we're going to do what's called a history. And this one is sample. Okay, sample's been around forever. It's the easy way to remember this. So we're going to do signs and symptoms, allergies, medications, past pertinent medical history or pregnancy, last meal, and events or mechanism of injury leading up to injury. Okay, then lastly, labs are diagnostic. Let's talk about blunt versus penetrating trauma. So I have two different kinds of trauma. I have blunt force, which is typically closed injuries. It can result in internal open injuries, but typically closed on the outside of the skin. I get hit with a baseball bat, and unless it had shards in it, or of glass, or nails, or something other sharp protruding from it, the belt hit me and did not break my skin. Now, it's not to say it didn't damage tissues underneath the surface of the skin, but it did not break my skin and is a blunt or flat force object. Whereas like penetrating objects, ice picks, knives, bullets, etc., rebar at high speeds or metal objects flying at high speeds can penetrate past the superficial layer of skin known as the epidermis, and it results in a penetrating trauma. Okay, you need to assess your mechanism of injury and ask yourself blunt versus penetrating. We have motor vehicle accidents, seatbelt versus no seatbelt's a very common one. California is a you will wear your seatbelt state. This is not the case in all states. Oh, excuse me. There are some states where you will not have seatbelts at all, and then you have to assess, well, okay, the person was traveling 70 miles an hour in the car. The car suddenly came to a screeching halt because it slammed into something. Well, that body continued at 70 miles an hour. What did it hit? And that's what we should be asking ourselves there. What did it hit? What kind of damage do I expect to see when I walk upon the individual? Lastly, we have GCW, gunshot wound versus stab wound. Obviously, one is a very low velocity projectile in the stab, the knife. I shouldn't even call it a projectile, but the knife is a low velocity stab wound, whereas the gunshot wound itself carries with it a great deal more kinetic energy due to its velocity. Okay, small object, absolutely. Barely, most rounds, most ammunition is roughly the size of my pinky, maybe a little smaller. However, when a small object carries a lot of velocity with it, its mass times velocity equals more kinetic energy and potential damage to whatever it comes into contact with. Meaning a bullet traveling, let's say you have a 90 grain bullet. Okay, and I don't expect you to know what that is. Actually, let's go up. Let's go up to 135. You have a 135 grain bullet. Okay, it's traveling at 1,000 feet per second. All right, that's going to do a lot of damage. And then, not to mention, if it hits something solid and bounces around inside the patient, then it'll do even more damage. Okay. Well, if you take that same bullet, a 135 grain bullet, and it travels now at 1,500 feet per second, it's carrying 33% more kinetic energy potential multiplier with it. Okay, so it's not 33% more, it's a 33% multiplier over base. And so what this is saying is the faster something is traveling, the more mass it has, the more damage it's going to do when it finally comes into contact with the surface. Now, obviously, when we do our assessment, and especially our head to toe and our detailed or secondary assessment, we're going to do look at everything. Okay, I'm looking at my abdomen, my chest. I'm looking at the face, the neck, the head, the spine, everything. We're looking to see what organs are affected by the injury. When I look at the abdominal, I'm looking at the peritoneal cavity, the pelvis, and retroperitoneal space where the kidneys lie. I'm looking especially for hollow organs, stomach, bowel, bladder, etc. And I'm also looking at solid organs such as liver, spleen is a common one that likes to rupture, and kidneys. Okay. If I suspect a vascular injury, arterial, spurting blood, bright red, venous, oozing at a higher rate, dark brown or dark blue, excuse me. But something I want to keep in mind here, your intestines are open and can actually hold the entirety of your blood supply multiple times over in your body. What this means is I could have an internal bleed or hemorrhage or rupture or a tear in my intestinal lining, be bleeding for days on end, never know, and then all of a sudden, boom, low blood pressure, tachycardic. I've been bleeding for days. I just started passing bowel. That's the coffee ground, looking bowel, and come to find out they've had a bleed for a couple of days. Okay, so you definitely want to be aware of the hollow organs. They are dangerous. Same thing with the bladder. You puncture the bladder, damage the bladder, something's happened. Suspect the blood will be coming out in the urine as well. Could be from the kidneys, could be from the bladder. So how do we assess? And this gets a lot of people. So we assess the abdomen by doing a couple things. There's 4 steps. We're going to visualize, and that means we're going to inspect. We're going to go ahead and we're going to auscultate first. We're going to palpate last. And the reason we palpate last is that on palpation, we actually excite the GI tract and the microvilli. We excite them and get them all hot and bothered, and it makes them want to move. So whereas I may not have prior had bowel sounds, all of a sudden now I hear, and it's the bowel sound because I stimulated the GI tract. Okay, just be aware that's a thing. So visualize first, auscultate second, look for bowel sounds, or you're looking for abdominal aortic aneurysms, that large whooshing pounding sound, and then palpate last. Diagnostic studies, X-ray, CT labs, DPL, and FAST. Okay, we can do a bunch of stuff. X-rays is the first line, CT second line. Labs, I'm looking for typically a CBC, potentially a CMP that could indicate other things. I'm looking also at my coagulation factors, PT, PTT, and INR. And then I'm looking at potentially doing an ultrasound of the organs as well. So doing a Doppler, if you will. And the Doppler allows me to see into the abdominal cavity, and you can kind of see it here. And we can assess the liver over here on the right, the spleen over here on the left, and other organs to ensure they are not ruptured and do not have blood collecting around them. Abdominal trauma, same thing. ABCs, we're going to do warm fluids. We're going to do packed red blood cells if indicated. Pain management, yes. NG-OG is the big one. Why? Because NG-OG on low intermittent suction permits for gastric rest. And the same thing with the Foley. I want to monitor strict I's and O's. I'm not giving rest, sorry. But I want to monitor strict I's and O's and pay very close attention to what's coming out of the patient. Also, I want to note the color of the urine, the frequency of the urine, my hourly output, and any other factors such as like odor, smell, or cloudiness. If you have exposed bowel, and you have what's called an evisceration, where you have bowel or an organ outside the abdominal cavity, you're going to go ahead and take bulky, sterile dressing, a 4x4 or a trauma dressing. You're going to soak it in sterile saline, and then you're going to wrap it around the bowel, kind of like a taco almost, if you will. And around the top of that, you'll do a big, dry, bulky dressing. We're going to compress bleeding wherever is necessary and possible. We can do pressure first, and by pressure I mean get some 4x4s, put it on the site that's bleeding, apply pressure very tightly. Do not lift up. Do not take off the gauze that you just put there. One of my biggest pet peeves is watching nurses. Oh, my patient's bleeding. Oh, my patient's bleeding. Applies pressure with a gloved hand or 4x4s, and then they like pull it all back to look underneath it. Is it still bleeding? Well, yeah, it's still bleeding because every time you pull back 4x4s and you tear them, you're going to result them, and you're going to essentially bring the clot with it when you peel them back. So if there was anything that was clotting, it's gone now. They'll start bleeding again. And then lastly, we're going to do damage control surgery for any ruptured organs, damaged organs, or bleeds internally in the hollow or solid organs. Do, 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 do. Facial trauma. So, you need to know facial trauma is a very real thing. What are our considerations here? It's real simple. ABCs, airway, breathing, circulation. Is my airway compromised? Yes. Requires immediate intubation management, potentially suction if I have foreign bodies. Okay. I'm looking for any mechanism of injury and I'm looking to see what caused it. Was it a vehicle accident? Was it a gunshot? Was it traumatic? Was it explosive? Was it a burn? You have a lot of questions that you need to ask in this particular instance. So don't be afraid to. So the maxillofacial traumas, they're defined by 3 categories of Lefort. I thought it was actually 4. I stand corrected, it's 3. We have the transverse maxillary fracture, okay, and you can see that here in number 1, where we come across the maxilla right here on the top. Second is pyramid fractures going over the bridge of the nose. And then we have our second one, and that's actually going to be the, my apologies for. And then we have the Lefort transverse maxillary fracture, and that's going to be from the zygomatic slash parietal region up and over the bridge of the nose and through potentially the posterior of the orbital socket. So really quickly, just making sure we're still recording. Moving forward, there's a couple things we have going on here. Okay, with maxillofacial trauma, we have to look at the ABCs, airway, breathing, circulation component. We're looking to see airway open, clear, maintainable. No, there's something in the way. We suction it out, we clear the airway, we stabilize it with either an OPA, LMA, or an ET tube. Okay. After we have stabilized it, potentially we may require further surgical intervention with what is called a cricothyrotomy, okay, with C-spine precautions, where we do a full spinal mobilization and we control hemorrhages and we actually insert an NG tube to manage any kind of issues in terms of pressure, and fluids, distribution, fluid in the airway, and this allows us to actually um, how do I put this? Manage and navigate the symptoms of maxillofacial injury. With neck trauma, this one's actually not too hard to understand. We have a lot of major blood vessels in this region here. Okay, some very important structures, no doubt about it. And as you can see, we got the superior. You see all these vessels. Look at that. This is actually a really good picture too. We've got nerves coming up through the neck. We have the sternocleidomastoid muscle right here. We have the thyroid muscle or the thyrohyoid muscle right here. Uh, we have a lot going on. The trachea, the epiglottis, glands on either side. We have a lot going on in these structures, and it's important to understand all the issues that can occur here in the neck. Now, one of the two biggest issues that we have with the neck are going to be either hemorrhaging or impairment of the airway. If you suspect that there's impairment of the airway or injury to the airway, there would typically be bubbling at the open wound site, if there is one, or there would be the presence of subcutaneous emphysema under the superficial tissues of the skin surrounding the neck right about here. So as you can see, we have, if we keep moving down, we have the larynx, trachea, we have our thyroid structures, blood vessels, we have the esophagus sitting posterior to the trachea. The trachea is definitely in the front. We have our, and if your Adam's apple also is in the front there, or cricoid and thyroid cartilage, and you can touch that with your fingertip. Okay. Neck traumas, anatomic zones. We can divide it into 3 anatomical zones or regions, and what we are essentially looking at is what area are we potentially injured in. Okay, so C1, C2 falls into zone 1, C3 through C6 falls into zone 2, and C7 would be zone 1. I apologize, I have these backwards. 3 is up here, 2, 1. Okay, but I've already given you kind of an acronym slash indicator to C4, C5, staying alive, and that's going to be right down here going into zone 1. So what are we going to do? We're going to do assessment of the neck. We're looking for any, we're going to do our visual inspection. We're looking for deformities, contusions, abrasions, punctures, penetrations, lacerations, tenderness, and swelling. We're going to go ahead and palpate the back of the neck and the front of the neck. I'm looking for tracheal deviation, jugular vein distension, subcutaneous emphysema, any medical alert tags that might be around the neck. And I'm looking for any step off in the back of the neck, spinal alignment issues at all. Looking for all those things because we're going to put a C-collar on here shortly, and I don't want to have to go back and reassess these particular structures. So, if there is any hemorrhaging, we will control it. I'll hold C-spine the entire time, and I will reassess the airway continuously as I do so. Musculoskeletal trauma is a very big one. Injuries occur in 85% of blunt injury patients, and that's absolutely the truth. Typically, what this means is, yeah, you got hurt by something blunt, but it results in injury underneath the surface of the skin, epidermis, dermis, subcutaneous tissues, and it could be hemorrhaging, tearing, swelling, hyperextension, fracture, break, etc. Perfect example of a blunt injury resulting in a major injury would be a cardiac tamponade. So you're in your motor vehicle, you're driving down the highway, you don't have your belt on, live in a state where that's not a thing. A car cuts you off, you slam your brakes on, but you slam into the back end of it anyway at 50, 60 miles an hour. You do not have your belt on, you go flying into the steering wheel, and you hit your chest on the steering wheel. It doesn't break the skin at all, but it impacts the chest hard enough to cause rupture or irritation to the pericardium surrounding the heart, resulting in swelling, inflammation, and cardiac tamponade eventually. Though there is no external presentation of cardiac tamponade, there's nothing on the outside of the body to say that something is going on. That is a good indicator of what would be happening inside the body. Again, blunt force trauma on the outside, but no injury, no penetrating, no nothing down to the heart, but the heart absorbing the kinetic energy being transferred into the body, resulting in internal injury. Moving on. Okay. Oh, some more excellent pictures. So you can see all these different structures that have, like, you get down here, we have the potential for the bladder to rupture. We have potential for, all this is going to typically be organ here, or excuse me, organ intestine here. We have major descending and ascending blood vessels. We have our kidneys left and right. I tried to scroll up right there. And we have our liver, pancreas tucked back here, spleen up here. Typically, stomach would be here front in the abdominal cavity, maybe a little lower. Above that, diaphragm, lungs, and then the mediastinum, the heart. Okay, so big deals here. Pelvis, looking for hypotension and blood loss. How do we look for blood loss? Well, there's a couple ways. And again, deformities, contusions, abrasions, punctures, penetrations, lacerations, tenderness, and swelling are our big ones. But there's also tenderness, instability, and crepitus. So when we assess for any skeletal, musculoskeletal injury, we're going to palpate and put offset pressure on the patient. What we're looking for is any kind of fluctuation, any crepitus, meaning it sounds like, rubbing two lava rocks together, that feeling, that sensation. That's called crepitus. And any swelling or deformity is huge. If you find deformity, do not continue like manipulating the extremity. Do not continue palpating it. Just be very, 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 very careful. If you suspect that there is a pelvic injury, yes, we're looking for hypotension due to bleeding, but we're also looking for blood in the urine or urethra, and we're looking for flank pain rotating down into the scrotum or the genitals. Extreme injuries, we can have lots of blood loss. We've already talked about open versus closed and vascular compromise. So essentially, we have uncontrolled hemorrhage versus controlled hemorrhage. I can control external bleeding. I cannot control internal bleeding in the pre-hospital setting, but there are some tools that I can utilize in the inpatient setting to control internal hemorrhages. For example, if you're say you ruptured blood vessels in your esophagus, I could go in there and band those with a gastro-duodenal esophageal endoscopy. We can go, an EGD. We can go down the throat, find it, band it, put pressure on it. We can do all sorts of stuff. Okay, but you got to go to the hospital first in order to control those. But then there's a lot of other bleeds, like say I have an intestinal bleed due to rupture, puncture, penetration, and I have an uncontrolled internal hemorrhage, dropping blood pressure, increased tachycardia, and the list just keeps going until I go into cardiac arrest related to hemorrhagic blood loss or exsanguination. So what are we going to do? We're going to do IV therapy for blood loss. We're going to replace that volume. Typically ISO. ISO is the key here, not hyper or hypotonic solutions, but we isotonic solutions. Colloids potentially if required. We're going to control the hemorrhage, direct pressure, splint the extremity to prevent further bleeding. We're going to use a masked sheet to reduce pelvic space. So in other words, we're going to band the pelvis together to decrease pelvic instability and blood loss. We're going to use a tourniquet if necessary. Amputations in the field are a little different than amputations in the hospital. If EMS came upon an amputated body part, they're supposed to wrap it and stick the affected or cut or incised end in a cold, sterile dressing with saline water directly on the open vessels and vasculature and tissue and nerves and blood vessels. So we're going to cover that, and then they transport it to the hospital. And then we also do the same thing on the other side. We cover the stump with a sterile saline dressing. The idea here is the saline keeps the tissue hydrated and viable for reuse if necessary. We're also going to manage pain, and we can do so with a variety of medications, many of which you already know. So I'm not going over those again. This is a pelvic binder, and earlier we saw that bookshelf fracture in the direct front here where the pubic symphysis was separated. This is exactly what that would be for. It goes around the pelvis, and we tighten it together, and actually brings the bones closer together with the idea that the closer the bones are together, the less likely they are to continue bleeding, the more likely they are to clot when we want them to clot. If you don't have a pelvic binder, not a problem. All you need is a bed sheet underneath the patient, wrap it across, around, twist, 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 and you actually have given yourself a pseudo pelvic binder. So, pretty serious stuff here. Pretty good stuff. Moving forward, we have our chest injuries, which are responsible for 1 in 4 deaths. I would definitely know that. Blunt versus penetrating. Most commonly, our blunts are related to fall injuries, motor vehicle accidents, assaults, especially with blunt objects such as baseball bats, pieces of wood. Penetrating fall into the category of being caused by gunshots, stab wounds, impalements. I fell on something and impaled myself. But for the most part, these are our most common. There are others, but these are our most common causes. Problem with this is thoracic anatomy being what it is, we have a lot of very important structures here. I have the lungs bilaterally, mediastinum sits right back here. Okay, I have my right atrium, my right ventricle, my left atria, left ventricle, my pulmonary arteries and veins. I have valves here. I have all sorts of really important stuff, not to mention the inferior vena cava and the aortic arch coming up over, touching the subclavian and coming down. We have a lot. So what I want to be on the lookout for, whether it's blunt or whether it's, penetrating, I want to be on the lookout for tension pneumothorax. And tension pneumothorax is something that occurs when you have a rupture in the lining of the lung, and the lung is now pouring all that breath that you would take in, you breathe that in, it's actually going right through the hole in the lung and going into the actual pleural cavity, putting back pressure on the lung. So I can get a good picture here. Of course I can't. Putting back pressure on the lung and causing the lung to get crushed. So what needs to happen here is two things. One, we're going to have to use positive pressure ventilation to reinflate the lung. And two, you're going to have to do a thoracentesis or a chest tube, depending on the severity. And the thoracentesis essentially allows all that escaped air out of the chest into the outside world. And boom, you can reinflate that lung. All the pressure is taken off of it. Now, if this is a persistent issue in which requires draining on a regular basis, the thoracentesis typically have a one-way pressure valve or a stopcock on them that allows the individual responsible for it, in charge of it, to actually bleed off the pleural cavity if it's suspected on the way to the hospital, or in the hospital, they have extra buildup of pressure and are unable to breathe and inflate that lung. Okay. Open pneumothorax, or also known as sucking chest wound, is a much easier to treat. So I'd like to point out, tension pneumothorax is actually going to be a closed injury typically, but I've had some blunt trauma occurred to the body. Inside my body, something's ruptured, typically the lining of the lung. And again, air is escaping out of the lung into the pleural space, crushing my own lung. All right, so treatment for that, positive pressure ventilation, typically a bag valve mask, and thoracentesis between the fourth and fifth intercostals. Now, an open pneumothorax is just how it sounds, sucking chest wound. It's actually a tear, or not a tear, a puncture, a penetration, or a tear from the outside world of the body, outside the thoracic cavity, into the thoracic cavity. Okay, and what happens is, like, once again, every breath I take, air comes into my pleural space, my thoracic cavity, and crushes my lung. Now, depending on how deep the penetrating trauma was, I may or may not also have a damaged lung itself. I might not just have tearing or penetration through the thoracic wall, but also through the wall and the lining of the pleural cavity, and also the lining of the lung itself. So I'm getting hit from both sides. So what we have is a loss of pressure that allows the lung to inflate, but we also have back pressure every time I take a breath. So what we would actually have to put over a open pneumothorax is called an occlusive dressing, and you need to know that. The direct treatment for an open pneumothorax or a sucking chest wound, wink wink shooting star, is an occlusive, OCCLUSIVE, occlusive dressing. So you definitely need to know what that is. Know what this is, know what the treatment is, please. Additionally, we can have massive hemothorax, meaning I'm bleeding inside my lung because I damaged tissues. Just like air can fill the pleural space and air can fill the lung, blood can do both too. And that instead of having a pneumothorax, we now have a hemothorax. Or if I have both, I have a hemopneumothorax. How do we know? You can percuss the chest or you can auscultate. Flail chest, wink wink shooting star, put a star next to this and write this down. A flail chest is described as two or more ribs broken in two or more places. These ribs, or flail chest segments, typically move in what is called a paradoxical motion. That means when I take a breath in and fill my lungs, my chest should be getting bigger, moving out and away from my body. That paradoxical section of two or more ribs broken in two or more places would actually suck inward. It's doing literally the exact opposite of what I would expect it to do. Wherein when I exhale, my chest should get smaller, come down in size, decrease in size, but that flail segment would move paradoxically and actually push outward. It would bulge away from my chest while I exhale. So it literally does. Paradoxical movement means the exact opposite of whatever it should be doing. All right. So I mentioned it earlier, definitely need to know what it is. All it is, trauma hits me, whether it's blunt or penetrating, typically blunt, hits my chest, damages the pericardium, damages the myocardium or endocardium, excuse me, and results in blood or fluid building up in the pleural sac. So how do I know? Well, you may not see it from the outside of the body, but I am looking for Beck's Triad. I'm looking for PEA's activity, and I'm looking for severely decreased cardiac output. Okay, the heart's going to try and compensate an increase in rate, but cardiac output is a different consideration here. This particular issue can be solved with a paracentesis, or a pericardial access, actually, or what is known as the pericardial window. And all we're doing is cutting open the pericardium and allowing for all that excess blood building up around the outside of the heart to effectively bleed off. So that's one way. Thoracic trauma. Let's talk about aortic dissection. Incredibly high mortality rate, and when your aorta, the aorta itself, having a aneurysm is just the state of having a weakened wall on the aorta. And the aortic dissection itself is when that weakened section or a section of the aorta is dissected, broken open, explodes, ruptures, and honestly, because of how large of a vessel it is and how much blood it's carrying, you're typically dead very quickly. There's nothing we can do. You could be open on the surgical suite table, and we would not be able to successfully treat this. That's how hard it is to manage this particular condition. So, look for signs and symptoms of hemorrhage. So, one of the big ones is a decreased blood pressure in one extremity while no changes in the other. We're looking for a widening of the mediastinum and deviation of the trachea to the left or the right, along with jugular vein distension potentially. But anyway, aortic dissection impacts the aorta. It starts tearing, or it tears on impact. You bleed out internally and die very quickly. Thoracic trauma, we have the myocardial contusion, pulmonary contusion, diaphragmatic rupture, and tracheobronchial disruption. Okay. Essentially what we have here is an outside force has acted on the lungs or the heart, has caused tissue damage, and that results in tissue damage has impaired our ability either to pump blood forward, increase cardiac output, or to pump oxygen into the body and to utilize that. Ooh, that's a pretty substantial mechanism. Where are we? No, no. So how do we do an assessment? It's real simple. ABCs or ABCDE, okay? Control your life-threatening bleeding. We're looking for MOI, detailed respiratory assessment. Already did that in ABC. Look for signs of shocks, SpO2, ETC, or end-tidal CO2. Are you breathing? Is your airway open and clear, maintainable? Are you, what's your rate, depth, and ease? Circulation? What's your rate, rhythm, quality? Those are the things that I need you to assess for and look at. How do we treat? Here's a big one, okay? O2 intubate is needed for thoracics. 2 large bore IVs with the potential theory I'm going to do rapid volume replacement or rapid blood cell replacement. And then we're going to stabilize any impaled objects and fix it to the abdominal cavity or thoracic cavity. I don't want it to move and I don't want to take it out. No, this is not a sword in the stone situation. I want to get this person to the hospital if they still have this in. The reason being I want to do that is because that object, once it's taken out, potentially could actually be obstructing blood flow and causing things to begin clotting or continue clotting. And by removing that object, we actually introduce the bleed all over again. We have the thoracic trauma treatment. What else? Needothoracostomy. We have chest tubes. We have thoracentesis, open pneumothorax, occlusive dressings, flail segments, splint stabilized segments, hemothorax fluid replacement in the chest tube, aortic dissection. We use beta blockers such as metoprolol for that. The list just really honestly keeps going. Essentially, it's this: if you're going to hurt yourself, try and stay away from your lungs and your heart. Trauma during pregnancy is another one of those big ones to put a star next to. One of the most common causes of death during otherwise healthy pregnancies is actually trauma. Motor vehicle accidents are up there, falls, and then penetrating injuries to the actual abdomen slash fetus or uterus itself are some of the bigger issues that we can run into. So remember, mom has gained weight, making her more susceptible to falls, imbalance. Mom has gained weight, making her more susceptible to injuries to joints, muscles, and bone. And then on top of it, look at where the seat belts fit on the body. And that's why there's a lot of aftermarket companies that make seat belts for pregnant women that actually relocate the location and pressure points of a belt. So even if you're in a motor vehicle accident and you don't get injured, it doesn't put any pressure on the fetus when the belt finally constricts across your lap during an accident, or limited pressure, I should say. Cool part is the fetus has its own little, suspension system, if you will. It's got the amniotic sac filled with fluid. It's a very good buffer. It knows how to do its job, and it does so very well. Maternal pelvic fractures are most common. Abdominal trauma, placental abruption, premature labor, ruptured uterus, and fetal death. These are all typically the causes of death to the fetus itself. I will point out that when push comes to shove, if a mother's body is placed in a position where, do I save my body? Do I activate the sympathetic nervous system and compensate for my body, or do I save the fetus or fetus plural? In this case, it will be that mom saves her own body first. So sometimes the sadder parts of trauma in pregnant patients is that mom had substantial blood loss or hemorrhage and did not have enough blood flow to actually perfuse the placenta in the fetus, and she ends up losing the placenta or the fetus. So, but actually, if the placenta abrupts, risk for mom and fetus. Premature labor, risk for mom and fetus. Ruptured uterus, same thing, mom and fetus. And fetal death is very sad. But again, if the mom dies and they aren't in a setting to where they can get these babies out very quickly, the babies will also die as well. I already touched on that. Same assessment, not a whole lot's changed. The only thing that's really changed here is the respiratory and cardiac status. Please remember, mom is compensating not only for her injuries, but she's also compensating for feeding 2, having a heart rate for 2, a blood flow for 2, oxygenation for 2, and as such, you may find that she has a little bit like an increased pulse, increased respiratory rate, has increased blood volume. Her diaphragm is going to be pushed up or superior in the thoracic cavity, so she may have diminished lung volumes, so hence the increased rate. Contraction and vaginal bleeding post, traumatic injury, and then if we ever wonder, does the fetus have a heartbeat, we can always use the Doppler to assess. Lastly, and this is one that has to do with the transportation of a female that is pregnant. There is such thing as called supine hypotensive syndrome. Wink, wink, shooting star again. Supine hypotensive syndrome occurs when the fetus is laying directly on the greater vessels, the aorta and the vena cava, decreasing substantially preload and decreasing drastically output as well, cardiac output by decreasing preload, but also substantially increasing systemic vascular resistance against which the heart has to push. So if you ever have a patient and they're laying flat on their back and they're in the hospital bed and all of a sudden I'm dizzy, below blood pressure, tachycardic, roll them to their left. If that immediately takes care of your problem, your patient was positive for supine hypotensive syndrome, meaning the fetus was laying directly on the spine, directly on the vessels, and crushing them and causing mom to pretty much pass out. It can be life threatening, but usually we find this before then and we roll mom off to the left or the right, and that takes care of the problem instantly. So, thank you so much, everyone, for coming to today's lecture. I appreciate you paying attention. I hope you got what you needed from it. As always, if you have any questions, feel free to ask.